then share. Okay, tumor immunology. So this, the book chapter gives you an idea. This is, second leading cause of death in the world, basically. It's cancer. And nobody likes to talk about it. Everybody likes to be on the, if we talk about it, it won't happen. But there's a lot of different things that have advanced in the last few years, and lab plays a key role in that. Okay, whether it's just screening individuals, whether it's monitoring immunosuppressive drugs, or chemo, whatever. I guess it wouldn't be immuno. That's more transplant. What else would we do? What else would we do with patients that come in? Not necessarily check their drug levels. What do we do with cancer patients? See where y'all are on knowledge. Why do they come to the lab? What counts? White counts, red counts. All right. So they're going to come in to be evaluated for white count 1 because the chemotherapy, right? Are they in a state of risk for picking up everything because they have no immune system left? Are they red cells being knocked out too because they go anemic and then they have to get blood? So we had a lot of patients we had one doc that would bring patient in, have them come in 2 weeks before chemo and go ahead and order 2 units of blood. And their hemoglobin would be 10, CRIP would be 30. And we'd do they really, are we really needing to give this patient blood at 10? You're going to you're asking a lot. But what he wanted to do, his theory is that if he got more red cells on board early, that it wouldn't drop as far after the chemo. So that kind of set them up to kind of maybe not have to be so bad, so weak, so sick. And then you're like, oh, now they're at 6 hemoglobin, let's give them 2 units. So we do that. So, and then they also.
Does that work?
I think it did. It didn't seem, he took a lot of heat in the area because of that, because all the other doctors were like, that's unnecessary. You're trying to give people blood that don't need it at the time you're giving it. Is that really what we should be doing? So it was kind of one of those debates in the lab. And so there was a lot of chit chat. There was a lot of complaining. There was a lot of, hey, let me tell you what this doc's doing. And I think he finally quit doing it, just kind of as pressure from the other family doctor. The other thing is that we can give medication to boost white blood cell, Neupogen. They come in to get their white cell count monitored. If it's low, they get a Neupogen shot, just like they get an Epigen shot for red blood cells. So we can do monitoring that way. So just kind of give you an idea. And then there's going to be a lot that we're going to talk about here on screening and screening tests, screening for cancer specific. So I wanted to make sure we took our time through this part so you would know when you did get an order for a CA-125, what that meant, those kind of things. So we're going to cover tumor biology. That's where we're going to start, kind of giving you an idea if you don't know much about tumors, what they are, why they're called that, what they're actually doing in the body. And then when they're doing that, there's antigens that get produced because of what they're doing. And then we can monitor those antigens. So we'll talk about the clinically relevant tumor markers. Then probably we won't get into the laboratory tests, maybe so, because that's a big part of what I want to spend a lot of time on. And then the immune defenses against the tumors, immunoediting, tumor escape, immunotherapy at the end. So it's a big chapter. It doesn't seem like a bit. It's only 25 slides or something like that. So it doesn't seem big, but if you get into it, it is big. Put it that way. So we'll start here, introduction to tumor biology. So we see things like, I don't know, I know y'all probably are worn out. You probably didn't read anything before today, right? Or do I do have people that free read every day? No? Okay. So it's all new. So things that it caught my eye. First thing that caught my eye was cancer. So you might know where cancer, what that means, the name. It's on page 279. Cancer is named from Latin word for crab. So that's, if you're into astrology, now you know why Cancer designated with the crab, right? Derives its name from the property of invasiveness. I guess a crab is considered to be invasive, which resembles the legs of a crab when viewed in a microscope tissue section. So this cancer cells branching off, basically it's how it got its name, as the cell does. So I thought that was pretty neat. Benign versus malignant. You hear that a lot, right? You hear that all the time. Oh, we hope it's benign, right? We're hoping for the best news. They found a tumor, and we're hoping well, benign tumors, let's look at that. Let's start there. They're composed of slowly growing cells that are well differentiated and organized, similar to normal tissue. These tumors are surrounded by a capsule, and that's very important, okay? Because if it's capsulated, that means what? It's contained. So that's good news, and that's what the doctors will always tell you. Oh, we found a tumor, and we think it's capsulated, which in other terms, that means we don't think it's metastasizing. We think we got it all right there. So when they find one capsulated, they're excited because they know surgically, if it can be removed surgically, they probably will tell you they got it all. That's kind of like the lingo there. So, so what contrast? Malignant, okay? Cancer, malignancies, malignant tumors are disorganized masses of cells. They're rarely encapsulated, and this allows them to invade nearby organs and destroy their normal architecture. So that is basically the simple way of talking about benign versus malignant. Some people have always thought, well, it's just, they need to grade it. They need to tell which cell, what kind of cancer it is, and that's going to tell us if it's benign or malignant, okay? So simple term is simple, benign, well organized, not well differentiated and capsulated. Malignant is very unorganized, not capsulated, and allows it to move. Okay, so metastasizes to other areas, and that's not good.
Can the capsule like break or anything? Is that something that can happen? Or is it just there?
It can, but you're hoping that it hasn't. I guess the main concern is that metastasizing before it's discovered. Like we have cancers, and the reason screening is so important is because if you can catch it, like, oh, something's rising, something's wrong. Maybe we have it early before it has a chance to, oops, I wish we would have seen this 5 years ago. Maybe we could have prevented all this metastasizing.
So saying that it's benign, is that like a stage, I guess?
We're going to talk about stages, but that's coming. So you're getting there. We're going to talk about how you stage a cancer, and that's why I wanted to introduce this, because all of this is, you've heard all this, right? You've heard this, and it's like, now it's time to kind of, y'all become the immunologist and know what's going on. Just not to break anything, but since I've got you, like, one more time, St. Jude, y'all heard St. Jude, right? Just down the road. They have discovered a treatment for COVID. Yay, right? They think they have. Right here at the vaccination stage. You know which two things they're, I'll give you two of our main immunology markers that we know the immune response does for inflammatory response. They've cited it, and they've searched antibodies against it now. Tumor necrosis factor and interferon. Okay, two things that they went after for a treatment. to slow that down, okay, to slow that cytokine storm. You remember we talked about that earlier? So that just popped up when I was waiting on your printing to finish, not to change the subject, but to give you some kind of good news today, since this is a very depressing lecture with tumors. So let's talk, we got some more to talk about. Tumor immunology, like this, best understood background, origin of cancer cells, differences from normal. Normally, and that's what we talk about, tumors are abnormal, right? Your body has gone from the normal stages of cell division, cell producing, new cell generation, to something has mutated that system. And now that system has been changed, okay? So there's mutations. So when we think of cigarette smoking, when we think of asbestos, when we think of chemicals in the water, you know, anybody from Hoxie, you know, seen that news? Like, hey, we're no-fly zone over our sewer tank, our sewer pond, where we collect water and maybe we reuse that after we clean it, right? They were worried about crop dusters flying over the pond and spraying in certain things and causing a bunch of ill growth in there. Anyway, that's another story. So those kind of environmental, we think of groundwater, like how's our groundwater? Like, do you know, if y'all ever watch farming go on in around this area, what they spray, what they put on their crops for pesticides, fertilize, all of that good stuff, all those chemicals, right? Where does that go? And that's kind of what a lot of the belief is that goes down, seeps into the groundwater. And then that groundwater is brought up and we consume that groundwater, and then we're getting carcinogenic exposure, okay? So all of that being said, normally cell growth divisions are carefully regulated by processes designed to rapidly produce new cells, inhibit cell division when there's enough, and limit cell lifespan through a normal physiological process of cell death, apoptosis. Remember I told you I was going to change my pronunciation of that to apop. Apoptosis. So that is what's known as programmed cell death. Okay. If a mutation occurs, then you get out of the control of the cell differentiation. So cancer cells are always growing faster than normal cells. They cannot be brought under control by the normal mechanisms, and we can't kill them. Like, normal cell death doesn't happen with cancer cells. So we're going to list here in a minute that you're going to see that's going to be really scary to think about, that these cells have beat that part of the normal life cycle of cells. All right, so tumor, let's do some definitions. Tumor is a Latin word meaning to swell. So that's Latin. And neoplasma, neoplasia, and neoplasma. Neoplasma, that's it. From the Greek word meaning new growth. All right, let's get that. Okay, so another thing before I switch slides, over on the other side, approximately malignant tumors are classified according to the tissue of origin. So I thought that was good introduction info. Approximately 80% of cancers are carcinomas. 80% carcinomas, meaning they derive from the skin or epithelial lining. Did y'all know that before today? Internal organs, like 80% of carcinoma. Internal organs are glands. About 9% are leukemias or lymphomas. Y'all gotten to that part of heme and heme? Leukemias and yeah, maybe. Touched, okay. Malignant white cells present in the circulation or lymphatic system, and only about 1% are sarcomas, which are derived from soft tissue such as fat, muscle, tendons, cartilage, nerves, blood vessels. So we get this American Joint Committee on Cancer. And so if we switch, and I don't think this is on a slide, so we're going to talk about it here. The next page, it talks about this TNM system, and this is what Heather was referring to, was staging of the cancer. And we all heard stage, right? So I thought this was very good for intro for you guys. Tumors are classified according to the size, extent of their primary tumor. So they call it T0 to T4. And that's not the stage yet, but we're getting there. The degree of spread to the adjacent lymph nodes, so you call it TO to T4, then you got NO to N3, and the presence or absence of distinct metastasis, MO or M1. So, for example, a breast cancer may be classified as T2, N1, MO. So that is the TNM system. So you got 3 different things to grade them with. So when somebody says, I graded my tumor and they called me T2, N1, MO, okay, that would involve tumors between 2 to 5 centimeters, so T's the size, in diameter, that has spread to 1 of 3 to 3 regional lymph nodes, but not spread to distinct sites. So it hadn't metastasized, but it has spread, it is in the lymph nodes, and the size is classified as T2. So your pathologist, our boss, when we think about it, really, they're grading these, and that's their job. They get that. And Preston, and tell us about, y'all work for the cancer docs, right? Y'all heard these gradings before? Okay, good. Y'all want to expand on that?
What are you talking about, like malignant versus like benign?
Like your job is to do what? I mean, what is the purpose of where the clinic you work at, the lab in the clinic? What are they mainly concerned with?
I mean, like diagnosis of cancer.
Right.
Like that,
So they're bringing the tissue of the tumor in.
yes.
And they are preparing it, sectioning it.
Mm-hmm. And then making slides out of it, and then the pathologists use it, and then they say what it is or whatever, and then we print out reports and drop them off to doctors.
Okay. So do they bring in, like, if we talked about spread to lymph nodes, would they send you a lymph node that's removed?
Typically when we get like a big specimen, like a lobe, like a lung or something like that, they'll find and cut off lymph nodes specifically to see if it's in the lymph nodes in the lung and the chest to see.
So you're part of the grading part of the tumor itself. So that's what they're doing. So I didn't know if y'all knew those 2 are working. Kathy and Preston are working in that lab. Anybody else doing any? And that's called what? What's that lab?
Doctor's anatomic pathology.
Anatomic pathology. Yeah. So that's something you want to do later?
Me?
Yeah.
Go be a pathologist?
No, like end up there. Like you're gonna
Maybe.
Okay. Run that lab. Yeah.
I don't know.
You oversee histos and cytos and
I don't know about all that.
huh?
I don't know about all that.
Who's your boss there? Who's over the lab?
So basically, like they have I guess you call it like an office administrator type lady. She's like the intern's boss.
Okay.
And then you have like a chief financial officer, and then you
Okay.
have the president, which is a doctor.
Yeah.
So they're kind of all our bosses.
Well, I know, but like who oversees the work in the lab? Who's running the lab? Nobody?
I don't know.
Or is it the pathologist?
I was gonna say, we don't ever see them. The only person I see that runs like cytology is Jerry, and
I know.
he's over like cytology specifically.
Okay.
Yeah,
But I
and
don't see like the actual doctor.
they have certain doctors that are over certain like departments. Like we have Dr. Hahn is in charge of cytology. He's the cytology supervisor.
Okay.
Versus like Dr. Locke is more like the histology side. I think the Dr. Sales are probably them together and oversee the rest of it.
Okay.
I would say. But I don't know for sure. It's not like apparent, I guess you could say.
All right. Thank you for sharing. So let's look at, this is what Heather was meaning. So the criteria also corresponds to one of the 5 stages. So when we call staging a cancer, we call it stage 0 to 4. So 4 is the worst, okay? Four is bad, and I don't know if you remember Alex Trebek was stage 4 pancreatic cancer. That's the way he presented it. That's what he was presented with. So let's look at that criteria according to the type of cancer. In general, stage 0 represents non-invasive in situ carcinoma. Okay, so remember carcinoma is mainly 80% of them. Stage 1 and 2 and 3 are tumors that are larger or that have spread beyond the organ in which they were first developed to nearby lymph nodes or tissues. And stage 4 tumors are those that have metastasized to distant sites. So when you hear stage 4, that means it's metastasized from the original organ where it was to another organ. So we see that a lot. Like they'll say, oh, he, probably had colon cancer, but now it's moved to the liver. They had a melanoma, but now it's moved to the brain. Okay, when that metastasizing, it's usually the bad part. There can be, I think of Lance Armstrong, the guy, used to bike all the time. He had testicular cancer, and it had metastasized to liver, brain, right? But it was a treatable cancer. It was more treatable. Once it was treated, then it basically went away, right? They ended up putting him in remission. And we're going to talk some about that too. So again, stage 4 being the worst because it has metastasized from the original spot. And that's why we want to screen for breast cancer. We want to screen for colon cancer. We want to screen for prostate cancer, is because those are screenings that we can do that maybe will keep the cancer in the area of origin and not be metastasized once it's found. Like, oh, yeah, I had this, I had a lump in the breast and I just didn't worry about it and I just went on about it. But then 10 years later, they did an x-ray and now I have lung cancer. Now I have liver cancer. Now I have whatever, that makes it harder. So the reason screening is so important. So what makes the cancer? A mutation in the proto-oncogenes and the tumor suppressor genes. So we have genes. We have genes in us that keep the cell division under control. If a mutation occurs, if a mutation occurs in that, then we lose that ability, and what they call it as cell division caretaking is a good way to think about it. So we have these that they lose their ability to basically take over. To keep it under control. So I wanted to show you the characteristics of cancer cells. So this is a long list from your book. Sustained proliferation, meaning they're constantly growing. There is no slowing down. They resist death, so they resist apoptosis. Okay, they're not under that same control of, hey, there should be a half-life for you guys. They induce angiogenesis, meaning new growth. Immortality, right? Can you believe that? We got cells that start growing that we can't kill. We can't get rid of. Invasion and metastasis, meaning they're going to invade other organs. And you hear this a lot, depending on where it's located. Like, oh, if it had been in the arm or leg, like I have a cousin who died of sarcoma at 18, and it was in his back. And the thing was, it had wrapped itself around the spine. That's where it was located. It had found a way, and it was there. And it was like, well, if it had been in his leg where most of these were, then we could have cut. We could have, taken that bone out, that section. And that would have been fine. But where it was located, it was couldn't surgery it. So they had to do the chemos and the radiation and that type deal to try to shrink it or to eliminate it. Avoid suppressors of cell growth. So, hey, normally I wouldn't let you, normally our bodies wouldn't let a cell go and go and go and go. Like, we got enough of you, so let's suppress that. Well, they've lost that. The cancer patient has lost that ability due to a point mutation, a change. Altered metabolism, evasion of immune defenses, and we're going to spend some time on that. Genomic instability, meaning they're always changing, okay? They're always like, we can't really get a figure. You could say, hey, I had that same cancer. Well, my cancer and your cancers aren't anything alike. The name's the same, but maybe the way it's producing and the way it's moving is different. So maybe the treatment for yours is not going to work for mine, or, you always get, hey, that's not too bad. I had an aunt and they had that same one and they got treated and they're living today. They've beat it 25 years ago. And then you hear somebody that got it like 6 months ago and they're dead. Same thing, same cancer, went to the same hospitals, and that's a different story about, where to go. It's really, it is, you would be surprised at where lengths people will go to try to beat cancer. Let's just put it that way. They will go anywhere they think there is a chance, and that's fine, right? But I've watched that. I've watched that personally with the family member, which was once they found a treatment, once they beat it the first time, and I don't know if y'all know anybody that has beat cancer, if it ever returns, that's when they need you. They need your support then, because they have lost it. They will lose a lot of what got them through the first time, emotionally, mentally, attitude-wise. It was a good fight. We beat it the first time. Everybody celebrated that. If it ever returns, they need you then. They need your support more then than they did the first time, because they will be depressed. They will be scared. They will be, I've already done this once. This is not good. The doctors all told me if it ever came back. So if you know anybody that has done that, please that is just personal experience with this awful thing of cancer. All right, so now we're going to kind of get into some more details. We got tumor-specific antigens, so TSAs. So these are unique to the tumor. They're coded by mutated proto-oncogenes and tumor suppressor genes. And one of these examples that we see is called BCR, ABL, gene rearrangement, and CML. And that's why I asked you how much hematology y'all got into, because CML should have been in your hematology 1 class, right? Anybody know what CML stands for? CML? Not a word? Is that coming up next week after you get back? Is that in E2? I don't know. CML is basically chronic myelogenesis leukemia. Y'all hadn't talked about the leukemias at all?
We had a diff with CLL, but other than that.
CLL, which you heard a little bit of it. Okay. All right. What is BCR? Anybody know? Anybody follow along? Breakage cluster region. So we got a BCR, an ABL. Anybody see what ABL stands for? No? Zoom, are y'all following along? ABL? I love abbreviations. Anyway, let's turn, if y'all look, let's see, I think I have a picture. Here we go. So this is normally on chromosome 9, a normal chromosome 9, and a normal chromosome 22. Okay, and what happens is the chromosome 22 breaks at the BCR gene right here. See that? And there is a rearrangement where this portion of chromosome 22 moves to where? Here's the ABL gene. So what we got is a change. See it? So a break at the BCR region moves this part of normally the chromosome 22 over to chromosome 9 where the ABL breaks, and the ABL ends up on chromosome 2, and it changes the name of chromosome 2 to what is known as Philadelphia chromosome. So there is y'all remember the video we showed, that I showed during orientation? You know, it was the Save a Life medical lab scientist, and they talked about translocation, right, of the gene, where part of it went to the other side, and we're going to get to this at the very end of the lectures of series, which is flow cytometry. Remember all that? It's kind of like to show you the end result of your degree before you started your degree kind of thing. Y'all don't remember that video? Yay? No? Not at
I
all?
had that meeting before you got here, so I probably didn't have that.
Oh, this would have been like in the fall when we did it virtually. This would have been in August. No? And we y'all zoomed in and I turned on the video and watched the video, fell asleep. Yeah. Anyway, anybody find ABL region of chromosome 9, what that stands for? Before we move on. Nobody?
BCR is breakage cluster region.
I got that. I've already said that once.
The
Yeah.
only thing I'm finding is
ABL.
it's a tyrosine protein kinase ABL1, also known as ABL1, and it's a protein located on chromosome 9.
There you go. This gene. Location. So what was the enzyme again?
Tyrosine protein kinase.
Yeah. Okay.
I figured we were looking for like an A word and a B word and an L word.
Yeah.
That's what I was looking
That's why I hate abbreviations. Hmm?
Epsilon proto cogene.
Okay. Yeah. I'm all with you guys. But yes, the reason I hate abbreviations is because you don't know if you're looking for a B and an L or BCR or an AB. I'm sure ABL has some.
It probably comes from the epsilon.
Yes,
name, if I had my guess.
that's where it comes from. Yes. All right. We also have something known as tumor-associated antigens. So these are more probably what you're used to seeing when you see stuff on here like CEA, alpha fetoprotein, prostate-specific antigen, CA125s. This is more of what we'll be collecting for. You may not be, maybe you'll get to a big lab where you're doing flow cytometry and looking at genes, okay? But more than likely, you're just gonna be at your local hospital here in NEA or St. Bernard's. That's why I was asking those guys back there about what they were doing at that pathological clinic. Are they doing anything gene related? I didn't know. But these associated antigens are expressed in the tumor cells and normal cells. Okay, so shared tumor specific antigens on many tumors, but not most normal tissues. So with melanoma tumors, there's this MAG protein, MAGE. What does that stand for? Now that I got you in that frame of mind. I thought y'all were going to be all over it next time around.
I see one that says melanoma on this side.
Yes, that's it.
It's the melanoma antigen gene.
The melanoma antigen gene. Yay. We have differentiation antigens on immature cells of a particular lineage. And this is where we see CEA, alpha fetoprotein, PSA, and then overexpressed antigens where we see HER2, CA125s, and CA19-9. Okay, so what do those mean? And I think, I was thinking I had a list, but I don't. I guess we're just gonna have to go with our list here. So what do you think? Anybody had their PSA done, guys? Had your PSA, y'all aren't old enough yet? Okay, PSA, prostate specific antigen, elevates when the prostate is unhappy. Okay, so it is a screening test for early prostate issues. Anybody know anybody's had prostate cancer? Yes, a few heads going up and down, yes. What are some of the problems with prostate cancer?
No babies.
Hmm?
No babies.
No baby? Oh no, you can still have babies.
Well, my uncle can.
Your uncle can't?
Yeah.
Don't you have issues like going to the restroom?
Yeah. Usually it's retention in the bladder. You have a hard time expressing urine from a male's perspective. So you might see, oh, it's real painful, right? I saw a lot of patients that come in that have painful swelling in their bladder based on their prostate being swollen and cutting off the urethra as it goes through the prostate gland itself. So we've had to catheterize that patient. Distension in the lower belly on a male. But with treatment, one of the things with treatment is impotency with it, and that's why most guys are scared. Huh?
Radiation.
Radiation.
Yeah.
A lot of guys are scared of becoming impotent if they have their prostate removed, so thus they avoid that. All right, they avoid the process of maybe getting prostate surgery or turn it down. Like, we think you have, a problem with your prostate gland, we'd like to go in and some will go to radiation for treatment. They also have one that they seed the gland with. They'll actually go in surgically and seed the gland with treatment to try to take care of it. But it is a scary one for guys, so that is one that you need to, but the CA1 or the PSA is what we use there. So when you look at surface markers, when we look, where am I? This is this is table 17.1, expressed on immature cells of a particular lineage. What else is up there? What about CA19-9?
Pancreatic.
Pancreatic, yes. So where we are is the categories of relevant tumor markers. These are carbohydrate antigens. CA19-9 is pancreatic and gastrointestinal cancers. So anybody had their CA19-9 done? Looked at? No, I haven't. I don't know how involved it would be. I think it would be just like the PSA, take a blood sample, serum sample. CA15-3 for breast cancer, CA125 for ovarian. And I have run CA125 or collected for them. I won't say I've run them, but I've collected for them.
I have a question.
Yes.
About, my grandma had pancreatic, she's gone now, but they didn't catch it until she already had it. So is C19-9 something that you only catch whenever it's like permanent?
I wouldn't think so. I mean, I would do more research into it, but I think CA199, if you had one that
Like,
did.
I don't know how to say that.
So what are the symptoms of pancreatic cancer?
I mean,
Pain is one.
weight loss.
Left pain,
dramatic.
weight loss. I know this is gross, but I maybe mentioned it, your poop floats. That's one of the ones everybody will tell you. If you start using the bathroom and your poop's not sinking, that definitely go be checked out, at least be screened. All right. It's just not a good one. There's very little treatment that actually works. It's what you do. But it's
I just-
an easy way to say that.
I was always told that you can never catch it early, at least early enough to do anything about it.
Well, as your book says, we are, and what we're going to finish up with. Let's go. I want to just do this. So I'm going to go and stop there. I think this is kind of what I wanted to do, just kind of get the conversation started, get your wheels turning. Go home for Thanksgiving and talk to just at the Thanksgiving table. You may hear some updates if you get to go home this holiday. So I'm going to stop the share. I'm not going to stop the recording because we're going to move to a website to finish up. Let me get to the website over here. There's a website that gives you the up-to-date, where was it? I know I read it somewhere. I gave you, anybody see the updo thing right quick? Here, where is it? I didn't write it down. I got it somewhere in here. It's like it says a website to go get the update on. Anybody see a website in the chapter? Where did I see it? Oh well, I can't put my eyes on it right now. I don't know if it's the screen. GAAs. It was an update on the latest immunotherapy. Oh, here it is. I found it. Okay. An update list of the tumor antigens resulting from mutations can be found at Cancer Immunity. HTTP. Immunity at. Oh, I just lost it again. Where was it? Oh, here it is. Cancerimmunity.org. Or peptide, right there it is. I think that's it. Yeah. Cancer immunology research. So I wanted to show you. There's supposed to be a list. Did I miss it? Oh well. Maybe I messed up. Maybe it's been updated. It was cancer immunity peptide mutations. That's what I had, right? Cancer immunity. There it was. What did it do? Mutations. And it took me right back to this, didn't it? Ah.
There was a dash in between peptide and mutations just now. So.
Oh, anyway, okay. All right, you guys enjoy your holiday. I'm going to end there. Sorry, I thought I could get to this. I didn't check it, but I was like, oh, that'd be fun to finish with. And we will see you with Zoom calls starting Monday after Thanksgiving. See you later, Zoom. Have a good one.